fixation. Hip biomechanics in intracapsular fracture neck femur is very peculiar, where the blood supply to the femoral head is compromised, which leads to increased risk of failure, loss of fixation, non-union, and osteonecrosis. Other factors such as the timing of fixation, choice of implant, the role of intracapsular decompression still remains controversial in 2025. So when we talk about these fractures, we have 3 or 4 categories. One, where the patient presents late beyond 3 weeks. One, which are pathological. And third, the one who have either a non-union or non-union with avascular necrosis. Powell's osteotomy is the treatment in younger individual, elder probably somebody else is going to speak about it later. In 1930, Powell described this osteotomy as a good option, wherein he medialized, and it was like a Y osteotomy where it was a pelvic supporting osteotomy earlier, which got modified subsequently. That can be combined either with a fibular graft, or you can use in a non-union isolated fibular graft and a choice of implant, either a screw or a DHS. 2 landmark papers, one which was published in 2025, April last month, where the outcomes of younger patients with femoral neck fractures were studied, and in them 1 out of 4 patients had a failure of primary fixation, and almost 15% had avascular necrosis. So these pattern is standard. The complications non-union following a failed fixation, osteonecrosis, or a malunion, and that needs a subsequent major reconstructive surgery, either orthoplasty or a proximal femoral osteotomy. Another paper published by the Femoral Neck Working Group, and in them it is a multi-center study, and for fracture who is involved, that is Colling, Michael Gardner, Paul Tornetta, and Michael Archidgon. So in them, they studied 492 patients with fracture neck femur, and the major complications occurred in almost 45, half of them, where in displaced fracture, and almost 1/4 in non-displaced fracture as well. So overall, 23% of this patient had failure of fixation and subsequent non-union, 12% osteonecrosis, 15% malunion, and by that the definition of malunion has changed, wherein if you have a shortening of more than a centimeter, it is called as a malunion. And out of these 492 patients, 32% required a major reconstructive surgery. Now, we are in a dilemma at the end of 6 months. How do you diagnose whether it is a malunion or it is a union? And for that, opposite side hip femoral head is superimposed on the operated side, and after drawing a normal anatomical axis, draw a perpendicular through the tip of the trochanter, and second one parallel to the femoral head. Now, this is a normal length what we expect immediate post-op, and subsequently at 6 months you can see the amount of shortening. So this is a modified overlay method. Other method of measuring a shortening is from the lateral cortex, you measure the distance of the screw head or between the distance of the barrel and the screw. So that gives you an indirect idea how much is the shortening. The valgus osteotomy, which has been standard as a practice for neglected and non-union or a delayed non-union, wherein the vertical fracture line, which is following a non-union, we always have a significant varus, and that angle is about 40 to 60 degrees. And if you try to fix them in that position, the shear forces does not allow the fracture to collapse or compress. And the vertical fracture gives rise to a shear forces which does not allow healing. So if you convert them to a horizontal by doing a valgus osteotomy, you can achieve a good result in them, wherein Uh, Various methods are used. One of them is a valgus intertrochanteric osteotomy using a 120-degree double angle plate, wherein after taking out the wedge, you correct the angulation and convert from 65 to a 25-degree, wherein we can achieve a union. The osteotomy is performed at the level just proximal to the lesser trochanter or at the level of lesser trochanter, and the proximal part of the osteotomy is parallel to the joint, the distal is oblique, and always leave that much part of bone between the angle of the plate and the plate. So leaving this bone gives you a adequate implant footprint and the osteotomy to compress. If this bone bridge, if you are lower down at your entry point, so if you do not have an adequate bone bridge, then you consider a osteotomy below the lesser trochanter so that you get a good compression. So if there is a lateral wall insufficiency, this is not an ideal site for osteotomy. We have to convert it to a subtrochanteric osteotomy. Whether one should do a intertrochanteric or a subtrochanteric osteotomy, the controversy is again related to how much bone you have on the lateral wall. Failure of the bone bridge is less common with subtrochanteric osteotomy. However, osteotomy healing being in the cortical area is delayed. Secondly, when you have that large segment of the proximal femur, it is difficult to control the proximal femur due to the muscular forces of rotators and abductors acting on the trochanter. So that is the controversy whether to do a inter or subtroch. If you have, the other is what should we do, whether we should take a full triangle, full wedge or a half wedge. The non-union neck leads to a limb shortening, and equalizing limb length is a desired goal when you are performing an intertrochanteric osteotomy. A valgus improves the leg length, but removing a full lateral wedge of the bone can compromise the limb length equalization and also significantly alter the axis, mechanical axis. So here is a half wedge osteotomy where for a non-union, if performed, can achieve a result like this. But you can see how much is the shortening which was there from day one, which is difficult to correct in those situations. A sliding technique, a sliding osteotomy where you don't need to take any wedge is removed in an oblique osteotomy, which allows the osteotomy surface to slide against each other like this to bring the correction. And the osteotomy always, the distal shaft medializes, thereby it is acceptable for a small correction, but the significant medialization of the femoral shaft can alter the mechanical axis subsequently. So here is a case where we had to do an open reduction, and in spite of that, a good fixation post-op, but it failed at about 4 months, and then a subsequent half wedge, lateral closing wedge osteotomy was done with a condylar blade plate, and that is a healing at about 9 months. Osteotomy further modified into a original Powell's osteotomy and a modified wherein the medialization of the shaft is prevented. Magu also described a similar osteotomy wherein he uses to lateralize the shaft a cortical screw so that the shaft doesn't medializes. Or the similar modification is you can use the removed wedge underneath the plate, and for that you have to keep the plate little out so that that wedge can be accommodated in the gap between the lateral wall and the plate. This is a neglected fracture, 6 weeks old, where you can see the complication where the shaft has medializes, even though patient is asymptomatic, but future, if he develops avascular necrosis or if the hip becomes symptomatic, the replacement will be an issue in the future. The choice of implant, we have angle blade plate.
We're going to stop that now. Sangeet, we're finishing the time. Yeah.
And dynamic condylar screw. So each have an advantage and disadvantage. A bone graft or a fibula which was used in a large series in Sandhu, either in various form as a single implant or a dual implant or a split fibula, has also been described. And to conclude, in patient younger than 55 years, it is desirable to preserve the hip, particularly in a patient's lifestyle and social and religious custom require squatting and sitting cross-legged. When the fracture neck of femur is more than 3 weeks duration, internal fixation alone has a very high failure rate, and it has to be combined with some type of bone grafting or a osteotomy, particularly in the young patients below age of 50. Thank you very much.
Thank you, Sangeet. That was an excellent.